So I'm Al Fisher. I'm an associate professor and chief of the Division of Geriatrics, Gerontology, and Palliative Medicine, and I'm here with.
I am Alona Balasanova. I am an addiction psychiatrist and the director of addiction psychiatry education for the Department of Psychiatry here.
And we're going to talk today about opioid concerns, specifically in older patients. So where this comes from is our division has a geriatrics workforce enhancement program, and this grant is from HRSA, and one of the expectations is to develop an educational program around opioids and to make this interesting and different than other training that we're doing for licensure and other purposes. We decided to focus it on specifically on older patients to make it very relevant for the GWEP educational focus. And importantly, our website is shown at the bottom of the slide here. So if you'd like to get a hold of the slides or any of the materials we're talking about today, you can go to that website or send one of us an email afterwards. So why are we having this talk? Importantly, it's that just like among younger patients, opioids are frequently used in medical practice related to older individuals. And as you can see in the slide here, about 9% of outpatient visits, specifically with older patients, involve a prescription for opioids. And if 9% of visits are about opioids, then it means about 9% of patients will take an opioid on a regular basis for chronic non-cancer pain. And importantly, there are patients that are presenting for treatment for opioid use disorders, perhaps as a result of being prescribed to opioids. And as we've talked about with younger patients, the evidence in older patients for the benefits of chronic opioid use are also pretty modest. And particularly, there was one clinical trial where what they did is they either put people on a fixed dose of opioids or they titrated the dose of the opioids to try to address pain better. And they found that even with titration, they weren't able to really show a demonstrable improvement in pain levels in these patients. Additionally, other studies have looked at other more patient-related outcomes like physical activity, physical function, sleep, mood, and quality of life in individuals with chronic pain. And in those studies, they haven't seen benefits from the use of chronic opioids. Additionally, older patients, there are unique concerns about the use of opioids beyond the ones that we think about in younger patients, where we're often focused on diversion, addiction, development of a use disorder. But older patients have those concerns and additionally ones as well. And so in particular, long-term opioid use is associated with cognitive decline, and even the short-term use of opioids can precipitate delirium in vulnerable individuals. A lot of times folks will talk about the risk of falls with using opioids. And interesting, when you do a deeper dive into the literature, it's not associated with an increased risk of falls, but it's actually an increased risk of injurious falls, meaning ones that result in fracture. And finally, there's also literature supporting that individuals using opioids are an increased risk for a number of outcomes that we would have really not thought of, such as car accidents, cardiovascular events, and this is specifically either a myocardial infarction or development of AFib, and also the development of pneumonia. So opioids are often used for these four indications: low back pain, osteoarthritis, neuropathic pain, and fibromyalgia. And this slide just indicates some additional options that we could consider as ways to either minimize the use of opioids or completely avoid them at all. So with back pain, for example, this would be things like using Tylenol, NSAIDs, SSRIs or SNRIs, or referring people to a pain clinic for things like a steroid injection. For individuals like with neuropathic pain, either using topical lidocaine patches, SNRIs, TCAs can be potential alternative treatments. For osteoarthritis, Tylenol, topical NSAIDs, and now Voltaren is available at drugstores over the counter. So this has added a new tool that patients can get access to and utilized to treat arthritis pain. And then also things like referral to physical medicine or orthopedics for a joint injection, or performing it yourself in clinic. And then finally, for fibromyalgia, approaches such as exercise, use of duloxetine or pregabalin can help with controlling pain.
So when you do get patients that are using opioids, it's really important to screen for opioid use disorders, right? Even in individuals who may appear to be taking the medications as prescribed, since we know that long-term use does raise the addictive potential of some of these medications. So there's a number of tools that are validated and evidence-based that we have available to screen for opioid use disorders. So the World Health Organization developed the ASSIST tool, and that stands for Alcohol Smoking Substance Involvement Screening Test. And it's an 8-item tool. It's available online for free. It's meant to detect and manage substance and related problems in primary and general medical care settings. It also includes a patient feedback card and is available in multiple languages. NIDA here in the United States has resources for assessing opioid use disorders, particularly the drug use screening tool, which is a 1 to 7 question screening tool adapted from the ASSIST tool, so it's just a little bit shorter and a little bit more for our population here versus internationally. You know, these largely focus on the underlying risks for substance use disorders. So family history, you know, over 50% of an individual's risk towards developing a substance use disorder is actually genetic. And so they're born with that risk. If a patient reports to be using opioids for a non-medical reason, that also significantly increases risk. And also, it's just highly recommended to use the prescription drug monitoring program we have in Nebraska, because you can check for prescriptions from multiple providers. We can actually see all prescriptions, not just opioids or just controlled substances, but it can also help us catch some dangerous combinations, such as getting an opioid prescription from one physician and then perhaps a benzodiazepine prescription from another, which can also contribute to some negative consequences in this population. So reducing harm from opioids, there's a variety of ways to do that, right? Harm reduction is kind of the biggest tenet of a substance use disorder care and just opioid related care these days. And so first and foremost, to somebody who might be opioid naive, you know, just prescribing acute opioids for very short durations for acute pain. So, you know, post-operative pain, fractures, that sort of thing. Most studies show that 7 days or less can actually be effective towards managing that pain, the acute pain. And subsequently, it can be managed with ibuprofen and NSAIDs and other over-the-counter remedies. Also offering treatment for opioid use disorder when indicated. So if you do a screening and it does appear that somebody, you know, may have some concerning signs of opioid use disorder, while not diagnostic, you could then pursue a, you know, a diagnostic interview or refer the patient to addiction psychiatry or addiction services for a full assessment and to treat the opioid use disorder. We can always encourage tapering and reducing the use of opioids. So coming up with a schedule with your patient on, you know, we're going to titrate very slowly based on whatever your comfort levels are and whatever the patient is able to tolerate clinically. Also offering referrals for buprenorphine treatment for patients unable or unwilling to consider opioid tapering. So again, that's something that we can help with in the addiction psychiatry clinic, where we can initiate buprenorphine maintenance therapies for patients and other therapies, as well as refer them to a methadone clinic if that's something they might be interested in instead.
Okay. And then finally, to wrap up, we have a couple of tools that we have created. And if these are ones you'd like to have one, definitely feel free to reach out and we can work to get one to you. So the first one is how to calculate the oral morphine milligram equivalent, or MME, that your patient is taking. And a lot of times insurance now will limit the number of MME that are available to patients on a given day. And so it's important to be mindful of how many you're prescribing so that you're not exceeding those limits, and perhaps either causing your patient to be flagged by insurance and incur additional costs, or triggering the sending of letters to you about consideration of tapering of opioids. And so to calculate the MME, the formula is shown down here at the bottom of the slide. You want to take your dose size. So for example, if you're using tramadol and you're using a 50 milligram dose, then you want to put 50 milligrams per dose. And then how often are they taking it? So if they're taking 50 milligrams twice a day, you have 2 doses per day. And then you use the conversion factor from the table above, which for tramadol is 0.1. And this gives you an equivalent, morphine equivalent of 10 milligrams per day. We also have a provider brochure that goes over a lot of the content that was in these slides. And so if you'd like one to refer to later, please reach out. And then if you're working with patients and would like to be able to talk with them about a lot of the content from our slides, we've produced patient handouts that are both in English and Spanish that go over the same content, but at a patient-focused level. So in summary, what we talked about today was that opioids are frequently prescribed for older patients and chronic use is not uncommon. Importantly, these opioid medications have additional potential harms in older individuals, such as cognitive decline and auto accidents. And these can concern about these can often be ways that you can lead into discussions with your patient because they may be more worried about these what we consider secondary outcomes than necessarily the risk of developing an opioid use disorder. And then finally, for individuals who are using chronic opioid therapy, consider screening for opioid use disorder, offering deprescribing or tapering, and referral for buprenorphine treatment if indicated. At this point, we'll stop and take any questions.
Please feel free to unmute yourself for any questions you may have.
Or you can put them in the chat as well. Okay. Well, thank you both for attending, and definitely be on the lookout for the survey, and we certainly would appreciate if you would complete it and send it back to give us feedback on the presentation.
Thank you.
Will do. Thank you.
Thank you.
All right.
Bye-bye.